Well, good morning and welcome to our fourth and final day of our Launch Telehealth virtual conference series. My name is Kathy Wibberley and I'm the director of the Mid-Atlantic Telehealth Resource Center, or MATRIC. On behalf of the MATRIC and the Northeast Telehealth Resource Center, or NETRIC team, I want to thank you all for joining us today. We have another outstanding agenda for you, starting with our opening plenary session with Lori Poole on the topic of innovation in the time of COVID and beyond. We also have a wide variety of breakout sessions that emphasize the depth and breadth of applications of telehealth, including the second in our telerehabilitation series. This one focused on applications of telehealth for OT, PT, and working with children with autism spectrum disorder. As an added bonus this afternoon, we'll be featuring a virtual exhibit hall with over 20 industry partners who would love to share their innovation in telehealth technology, their telehealth and consultancy services, as well as their telehealth education and training offerings with you. Take a few minutes to peruse their company profiles and offerings before joining them in their virtual exhibit booths. For those joining us for the first time, just want to provide a brief overview of who we are. The MATRIC and NETRIC are two of 12 regional TRCs, or telehealth resource centers, federally funded by the HRSA Office for the Advancement of Telehealth within the Federal Office of Rural Health Policy. TRCs provide free consultation and technical assistance to providers and organizations and agencies located in the United States and along the affiliated Pacific Islands in order to advance the use of telehealth technologies as a way to increase access to quality care. There are also two national telehealth resource centers. One is focused on telehealth policy and the other on telehealth technology. Together, the 14 of us make up the National Consortium of Telehealth Resource Centers. As you might have imagined, TRCs have been extraordinarily busy as a result of the COVID-19 pandemic. COVID has been a driving force for both digital transformation in healthcare and similarly transformative changes in telehealth policy. We're all excited to see what the future holds. We want to especially thank the many individuals who have worked tirelessly behind the scenes to make this virtual conference series possible. These include MATRIC and NETRIC staff, our AV team, and our many colleagues who have volunteered as moderators and poster presentation reviewers and more. Before we get started with this morning's plenary session, I wanted to take this opportunity to announce the winners of the annual MATRIC Breaking Barriers Through Telehealth Award. Each year, we seek nominations that tell a compelling story of a telehealth program or project from our region that has made a difference in helping address an unmet need or has led to improved health outcomes and quality of life. We received a large number of outstanding nominations this year. So please join me in recognizing and congratulating the following 2020 Breaking Barriers Through Telehealth Award recipients. And if you are one of the winners, I will be reaching out to you by email with more information shortly. So honorable mention for our Category 1, which is our Small Rural or Safety Net Provider Organization Award, goes to the Virginia Hepatitis C Education and Patient Connection, nominated by Terry Kemp-Nick. The program is a partnership between the University of Virginia and the Virginia Department of Health to provide collaborative care for hepatitis C in the rural Appalachian region of Southwest Virginia. Our Category 1 award goes to the Queen Anne's County Mobile Integrated Community Health Program, nominated by Jared Smith with the Queen Anne's County Department of Health in Maryland. The Mobile Integrated Community Health Program team consists of a community health nurse from the Department of Health, a paramedic from the Department of Emergency Services, a pharmacist from the University of Maryland Shore Regional Health Facility in Eastern Maryland, and, as needed, a peer recovery specialist or licensed addictions counselor. Honorable mention for our Category 2, which is All Other Organizations Award, goes to the Overcoming Barriers of Autism Spectrum Disorder at the Virginia Institute of Autism, or VIA. The program was nominated by David Cattell-Gordon and Elke Jones-Zavitz. In response to COVID-19, VIA has successfully transitioned its in-person school program, outpatient behavioral health services program, and adult program to the use of video-enabled services. And finally, the Category 2 award goes to the North Carolina Statewide Telepsychiatry Program, nominated by Sai Saeed with the Brody School of Medicine at East Carolina University. The program provides telepsychiatry services to individuals experiencing acute behavioral health crises in hospital emergency departments across North Carolina. Since its inception, the program has realized a return on investment of over $30 million by preventing unnecessary hospitalizations. And without further ado, I'm going to hand off to Danielle Lauder, Program Director for the NETRC, to introduce our plenary session speaker.
Thank you very much, Kathy, and thanks to everyone who has joined us here for our 4th week. And we are so excited and so fortunate to have Lori Poole here with us today. The Netric team originally met Lori a couple of years ago when we invited her to be our keynote for one of our in-person conferences. And we were just so amazed at her leadership, her innovation, her storytelling capacity that we said, wow, we really want to bring Lori to this virtual event series. And so we were so fortunate that she was available to be here with us. As mentioned earlier, Lori is Vice President of Clinical Innovation at the Ontario Telemedicine Network, which, as folks probably know, is one of the largest, maybe one of the largest globally telemedicine networks and one of the most long-standing. And Lori has been a leader within that network for many years, both from a clinical perspective and really from an innovation perspective in her current role, and really has worked across system transformation and is just always willing to share her time, her expertise, her knowledge. And so in keeping with our weekly goal of really wanting our speakers, our experts, to be able to spend the vast majority of the time here with you today and share their knowledge, I'm going to keep this very brief. The rest of Lori's bio can be found in the app, as always. And I think without further ado, thank you so very much, Lori, for sharing your time and expertise here with us today. And I'm going to turn it right over to you.
Thanks so much, Danielle. And Kathy, thanks for opening up this morning. And congratulations to all the honorable mentions and the award recipients. You're doing amazing work, and it's wonderful to hear about some of the virtual care innovation that is going on in the Atlantic region. I'm thrilled to be here with you this morning. I'm based in Toronto, Canada. I pretty well haven't left my desk for the last 4 months, and I was thrilled when Danielle reached out to me and asked if I would share our perspectives during this pandemic. As Danielle also mentioned, I was fortunate to be invited to Portland, Maine a couple years ago. It was a wonderful experience. I met a number of you, and I'm actually from Atlantic Canada. I grew up in New Brunswick. So I spent a lot of time in the eastern part of the US growing up. I'm looking forward to getting back. Atlantic Canada has not opened up their bubble yet, but I'm hoping to get back for my nephew's wedding in September. So certainly been strange times, but we're all in this together, and I hope that you're all staying safe. So what I'm going to do this morning is just give you an overview of OTN, who we are. As Danielle said, we've been around for a long time, and it certainly is our moment for virtual care in Ontario. I'm going to spend some time talking about our experience during this pandemic. It's been quite remarkable, and I'm sure you all have amazing stories to tell as well. But tell you a bit about our experience, some of our numbers, some of our growth, and just talk about a few examples of some innovation during COVID. And I really want to emphasize that a lot of this innovation came from our partners using non-OTN solutions. And that's exactly what we want to happen. We know that virtual care is becoming mainstream when healthcare organizations and providers are using their own solutions. And then just kind of wrap it up to share where do we go from here. And then I really would really love to hear your questions and your experiences. So hopefully we can have a lot of time for questions and discussion. So just to set a little bit of context. So Ontario, I'm just going to minimize myself here. If you just give me a second. There we go. So Ontario is Canada's second largest province. We're pretty large. We have about 1 million square kilometers, and we have a population of about 13.5 million. And we're actually home to about 2 in 5 Canadians. More than 85% of Ontarians live in urban centers, and it's largely in cities on the shores of the Great Lakes. So if you see the blue, the green, and the yellow, that's where about 12 million Ontarians live in the province. So you can see that salmon-covered area of the province is Northern Ontario. It's a vast, vast landmass, and there's about 1 million people that live in Northern Ontario. It's also home to over 100 First Nation Aboriginal communities. So when we started telemedicine, back in the 90s, we spent a lot of time working with our partners in Northern Ontario because of some of the challenges around rural and remote care and those residents not having access to care. So that's Ontario. Danielle, she mentioned, referenced that OTN is one of the largest, most integrated telemedicine networks in the world. We were formed actually in 2006 by merging 3 regional telemedicine networks. And our Ministry of Health at that time really had a vision. There were 3 telemedicine networks in different parts of the province that were disparate, that were not connected. It was very early days. They were funded by regional grants, by federal grants. We kind of cobbled together our funding because we're pioneers. And we really saw the need to provide better access to care using telemedicine. So we were working away, and the ministry came to those 3 regional telemedicine networks and said, look, we want one telemedicine network in the province. It'll be provincially funded. So can you come up with a strategy? So that seems like it was just yesterday. So we've been doing that since 2006. We were an organization of about 170 employees. With the provincial election in 2019, there was a new government that was elected, and one of their priorities was to transform healthcare delivery in the province. And they made the decision to centralize a lot of healthcare in the province and created a new agency called Ontario Health. That represented about 20 agencies that were brought under one umbrella. OTN was left out for the first year, but it became evident very quickly that virtual care was really a key enabler to transforming healthcare in the province. So this past April, we actually transitioned into Ontario Health, and our new name is actually Ontario Health OTN. And we went from being an organization of 170 employees to 12,000 employees. So it's huge. So it's been a bit of a transition. We also transitioned in during the pandemic, but it really gives us just a platform to really scale virtual care and to be part of a central agency that'll be part of the core strategy. And the CEO of that agency is Matt Anderson. He was a hospital CEO. And he was also on OTN's board of directors for a number of years. So he really, really gets virtual care. So despite the change management associated with growing and being part of a large organization, we really see it as a value add for virtual care in Ontario. And our vision is actually very simple. We want every Ontarian to have access to the best healthcare when and where they need it, regardless of where they live in the province. And our mission is all about partnership. We are a service network. We are an expert in virtual care. We do not deliver virtual care per se. And so we work very closely with our partners to inspire and accelerate virtual care that better connect people and care across Ontario's healthcare system. So when I talk about virtual care, we refer to it as telehealth or telemedicine or telecare. There's a lot of terms, as I'm sure that you live with every day. So we call it virtual care. And how we define virtual care is the delivery of healthcare over a distance. It can include video, it can include the phone, secure messaging, remote monitoring. And our goal really is about the patient, is to provide better patient experience and outcomes and better value for the healthcare system. We see virtual care as being a service and not a technology. Virtual care is delivered by people, it's patients and consumers that benefit, and we really see technology as being the enabler. So that's, I'll refer to virtual care throughout my presentation, just so that you have a context. So just want to spend a few minutes talking about our strategic goals at OTN. We have really three priorities. We want to improve access to specialized care. You saw in the map of Ontario that we have that vast landmass, so a lot of virtual care is delivered continues to be delivered in Northern Ontario, but we have so much more urban virtual care as well. So we want to optimize access to specialized care regardless of where the patient lives in the province. We want to help reduce wait times, and we want to reduce the cost of specialized care. Very, very important in terms of providing access to patients. A second pillar is we want to reduce pressure on hospitals. We have a term in Ontario that we call hallway medicine. Because a number of patients that go to the hospital end up in the hallway because the hospitals do not have capacity to admit those patients. So we really want to work with our partners to prevent avoidable admissions, to improve transitions in care, and to move more hospital from care to the home. And our third priority is that we want to modernize consumer access to care. So as you know, technology is ubiquitous in pretty well every other industry. Banking, travel, it's been a bit slower coming to the healthcare system, but that is really changing, and we've really seen that during this pandemic. So we have a number of initiatives underway that we really want to modernize consumer access to care, and we want to put care, in the mobile device, or in the hands of the patient. So some of the initiatives that I'll talk about is that we're modernizing access to primary care, and we want to provide a simple single point of access to innovative mental health programs. In order to do that, we have a number of enablers, kind of our foundation, to be able to deliver on our strategic goals. So we have a provincial platform. We really are experts in virtual care. Ed Brown is our CEO. He's my boss. I've been working with Ed for about 15 years now. He was one of the creators of the Legacy Network. He is a former president of ATA, and he's also an ATA fellow, just very, very passionate about virtual care. And as a former physician, worked in the emergency department, and really saw the need to be able to provide virtual care. So we have a lot of experts that have been doing this for a long time, and so we really want to be able to help the healthcare system with their priorities and help them adopt virtual care. As I mentioned, we do this with a number of partnerships across the province. We provide a lot of data and intelligence. We have pretty robust systems that are able to capture data on what is happening with virtual care in Ontario, and that's very important for planning and policy. And we're really transforming. We're really helping to transform the delivery of care with the ministry. And now that we're part of OH, we'll have a larger opportunity to be able to do that, and working very closely with our regional partners. So just to break that down a bit further, to talk about some of the examples around our strategic priorities, around improving access to specialized care, a core part of our business continues to be video visits. So you're all very familiar with that. We've been doing that for a long time. So we connect providers and patients. They use our platform to be able to do that. We pretty well support every therapeutic area of care. Mental health and addictions are large users, oncology, general internal medicine, and the list goes on. And because we've been doing this for a number of years now, we're pretty well integrated across the province with respect to our network being used province-wide. As part of our service, we have a provincial directory. So that's really one of the benefits of providing an integrated telemedicine network, so that if you're a member of OTN, you have access through our hub to all our products and services. And we provide a directory of all of the healthcare providers, physicians, nurses, allied health professionals that actually are available for virtual care. So healthcare providers that are looking for a specialist or other providers are able to access our directory and reach out directly to those providers to schedule an appointment. We also have a scheduling tool that you can either self-schedule or you can work with some of our coordinators to help schedule a virtual visit. So that continues to be a core part of our network. We also provide online consultation, so what is known or previously known as asynchronous virtual care. So we started probably about 10 years ago doing teledermatology. That continues to be widely accessed in the province. We also do retinal screening province-wide. We work with a number of partners who provide a lot of the resources to do online e-consult. So again, that is growing. We pretty well provide every therapeutic area of care. So that's access to specialists, and primary care providers can access those specialists, send an image, send a consult, and the wait time is, the average, reduces the average wait time from 53 days to about 2 days. So it's pretty remarkable. So there's a huge level of satisfaction with the provincial e-consult service, and it also avoids in-person patient referrals. The second priority around reducing pressure on hospitals, again, that's around preventing avoidable admissions and providing more care in the home and in the community. So for over 10 years now, we've been providing a remote monitoring program, really focusing on patients with complex chronic diseases, specifically heart failure and COPD. We probably enrolled over close to 20,000 patients in a remote monitoring program in the province. It's a 6-month program. It's really focused on health coaching. Patients get a home kit, a remote monitoring kit delivered to their home. You're probably all familiar with this. It's been around for a while. So they get a tablet with a blood pressure, cuff weight scale, and a pulse oximeter. So they send in their vital signs daily. And it's connected to a care team. So primarily a registered nurse or a registered therapist, or respiratory therapist that does the daily monitoring. But the real focus of that program is helping patients better understand what triggers their chronic disease. So we focus on a diet, we focus on lifestyle and medication management. And we've seen a huge reduction in health system utilization in that they spend fewer days in the hospital and they actually go to the emergency department less frequently. So some pretty good outcomes with that program. And again, that is province-wide. Something that we started doing a few years ago is innovation procurement. So just leveraging the experience that we've had through our remote monitoring program, we realized that there are other clinical needs that could really benefit from a virtual care solution. So because we work so closely with our partners, we really wanted to understand, what are their big challenges? And some of those challenges were around providing more home-based palliative care, better wound care, better tools to be able to support patients from hospital to the home, post-op, so looking at some surgical transition solutions, substance use disorders, and mood and anxiety. So better understanding what their needs were, we went out and procured solutions to help them use those type of solutions with their patients. And how that benefits the providers is it eliminates the need for them to do a procurement, so that we procure on behalf of the province. We negotiate the pricing, and then if any hospital or any provider wants to procure one of those solutions, then they do a second stage procurement and get the provincial negotiated price. So it just makes it much easier for them to be able to procure a solution. And then we will help them implement the program. So that was pretty innovative a few years ago, and we've had better success with some of those solutions, and I'll talk about that later on. Our third area in terms of our priorities is really modernizing consumer access to care. So we started with online mental health solutions. And one of the solutions that is province-wide, and it's actually direct to consumer, is called Big White Wall. And this is online peer support for people that are struggling with mild to moderate depression and anxiety. They can log on to Big White Wall. They can do it through a PC or through a mobile device. It's anonymous. It's available 24/7, monitored by Wall Guides. We introduced that probably about 2 years ago in Ontario, and it's really taken off. Based on that experience, we know that there continues to be a lot of challenges around mental health issues in the province. And so we were asked by the province to roll out internet-based cognitive behavioral therapy. So we started doing that last year, and we rolled it out with universities and colleges. That is a limited pilot right now, although once the pandemic started, we've rolled that out province-wide. So I'll talk about that a bit more as well later on when I talk about some of our experiences during the pandemic. Based on primary care in the province, when we were doing some analysis, we found that about only 45% of patients in Ontario can access their primary care provider for next day care. And so the province asked us whether or not we could look at a pilot to provide better access to primary care. So again, this is a pilot that is underway right now. We're working with about 400 primary care physicians that provide a online access to a solution for their patients. Patients log into that solution and are able to connect with their primary care providers either by audio, by video, or by secure messaging. Our experience to date has been quite remarkable for patients, and the most popular modality is actually secure messaging. So those are some of our initiatives around achieving our priorities. And it's been pretty exciting to work with our partners as virtual care becomes more ubiquitous. So how do we do things in Ontario? So as I mentioned, we are one provincial telemedicine network in the province. We operate on a membership agreement. So healthcare organizations, and pretty well every healthcare organization in the province is a member of OTN. So they sign a membership agreement and they have access, they have free access to all of our tools that are available in our hub. So you log on to our hub and you have access to our video, to eConsult, and all of our other programs and services. And you know, it is very integrated. We spent a lot of time kind of on that provider journey because we have to make it very, very simple for providers who are very busy to be able to access virtual care in the province. And it's very important for us to be able to focus on equity and access. So we work with a number of Aboriginal communities, French language communities, to make sure that they have access to our telemedicine network as well. So our process is further supported by hundreds of patient host sites at local health facilities across the province, which enables patients to get care that they need in their own community. So how it works is that a number of hospitals will have what's called patient access networks. A patient will go into that host site and then they will connect remotely with a specialist who is in another region of the province. So last year, I should say, probably fiscal year 2018-19, we facilitated over 1 million video visits, and about 125% of those video visits were directly into the patient's home. So how it works in our province in terms of billing for physicians is that up until the pandemic started, physicians could only get reimbursed for virtual visits if they used OTN's network. Now that was started back when OTN was formed in 2006, and it was a way to really incent physicians to use virtual care in the province. So a lot has changed, and so physicians will use OTN. They submit their billing. There's a premium for those virtual visits. But we know that the world has changed. And a lot of hospitals and a lot of healthcare providers have their own technical solution. There's Epic that uses Zoom. There's a number of solutions now. So we're not the only game in town. And that's actually really, really good news. So the reason that we had to do this is because nobody else was really doing it. But now that there are a myriad of solutions, we've been working with the ministry to say, okay, how about, we look at a transition so that physicians can bill using non-OTN solutions. So 2 years ago, we started a partner video program, and we worked with a number of hospitals to use their video solutions and that they could bill for non-OTN solutions. So again, all this work was started pre-pandemic. And since the pandemic started, it's kind of blown the roof off of billing in Ontario, which I'll talk about during our experience. But the bottom part of the slide just talks about some of the benefits and some of the value to virtual care. And I'm sure majority of you are very familiar with this, that providers that use virtual care are quite satisfied, and patients, we've always had a very, very high level of patient satisfaction, and that majority of them do not have to leave their communities, and they're very happy that they don't have to. In the northern part of the province, some of those communities are 10 to 12 hours away from an urban telehealth center, so it's a lot of travel for them. So I want to spend a little bit of time talking about video visits to the home. So as I mentioned, prior to the pandemic, most video consultations in the province occurred with the patient attending at a local health facility, often with support of a nurse. So there are about 2,000 telemedicine coordinators in the province that support patients at remote sites. And these remote sites can include hospitals, primary care, and a number of community settings. So home video visits, which we're now calling direct to patients in their homes, started to grow in 2018, largely due to an OTN pilot that enabled about 600 physicians to begin to bill for these visits. So this was a pilot program. And in these cases, patients use their own devices. So they had to have a tablet or a PC or a mobile device in their home. So we worked with the providers on the workflow, on the patient criteria, on all the instructions to be able to kind of test this as a pilot. So as I previously mentioned, in 2019, there were about 125,000 home video visits with patients using their own devices in their homes. This also included not just physicians, but non-physicians as well. We had nurse practitioners, speech pathologists, PTs, OTs that were able to use home video visits as well. So this was really going into a very successful pilot, and the ministry was really concerned about opening it up because of the demand on the financials in terms of everybody doing this at once. So they really kind of wanted a staggered approach. They wanted to make sure that it was safe and that it was secure. And in November of 2019, the government actually announced a digital first for health strategy. And a new fee code was introduced, which allowed all physicians to bill for direct-to-patient home video visits using, again, just the OTN software, with kind of a vision down the road to be able to open it up to non-OTN solutions, but it was going to be a bit of a staggered approach. So I just kind of want to set the context because a lot of that changed during the pandemic. So I'm going to move on now to talk about our experience during the pandemic in Ontario. So our experience is that the government declared an emergency on March 17th. And as you all know, that was to help stop the spread and the spread of coronavirus and to keep people safe. The announcement was made following Ontario's March break. So up until that point, we were able to trace back cases where people became infected. Tens of thousands of people went away on March break in the province, so it was inevitable that we were going to have community spread with this pandemic. So the declaration remains in place in the province, and it's gradually reopening using a regional approach. We are about to go to phase 3 in certain parts of the province. The pandemic primarily is in the Toronto area, in the southwestern part of the province. So the government is being very tentative and phasing out our reopening. As of July 11th, the total number of COVID cases in Ontario stands at about 36,000. Canada-wide, it's about 107,000 cases. The total number of deaths in Ontario is about 2,700. Compared to Canada-wide is 8,700. About 2/3 of the deaths in Ontario occurred in long-term care homes, and 8 long-term care workers, personal support workers, have also died of the virus. We've had a real challenge with our long-term care settings, and those deaths occurred largely because of the fact that there were 4 patients in one room. So that resulted in a rapid spread of the virus. We continue to struggle with outbreaks in the southwestern part of the province due to the living and working situation related to seasonal migrant workers. So we have about over 8,000 migrant workers that come into the province, every spring to work on farms. And they live and work in very, very close quarters, and a number of them have become infected. So there's a lot of effort to be able to resolve that situation in the province. So we've not come out of this without some tragedy, but there's been a real commitment to take a staggered approach to mitigate any more deaths and to mitigate the growing number of cases. Just thought I'd share with you some of our numbers that we experienced at OTN. Previously, as I mentioned, we had about 1.1 million virtual visits with over 125,000 into the patient's home. Between March 1st and June 30th, we actually had about 736, almost 740,000 virtual visits, and 74% of those visits were directly into the patient's home. So literally, primary care offices were shut down overnight. They were not seeing patients face to face, and they went directly to video. So you can see that previously, we had 1.1 million visits over a 12-month period, and we had almost 740,000, in 4 months. So huge growth in our volumes. We've also brought on a number of new providers over the last 6 months. We've onboarded around 10,000 additional physicians and 17,000 RNs and allied health professionals. Prior to the pandemic, our daily volume on our network was about 1,000 virtual visits per day. We're now at about 12,000 video visits per day, and we're not expecting those volumes to decrease. So it's been an incredibly busy time for our infrastructure at OTN, and it's really been all hands on deck since this pandemic started. The other thing that the ministry did was in late March, the ministry announced temporary fee codes for non-OTN solutions. So as I mentioned earlier, prior to the pandemic, physicians could only be reimbursed for virtual care if they used OTN. We didn't have the capacity to be able to handle the tens of thousands of virtual visits that literally happened overnight. So it was very smart of the government to be able to say to physicians that you can bill for virtual care using a solution of your choice. And that also includes audio visits so that they can bill for phone calls as well. So we only have the figures for OTN. We're working with the ministry and OH to try to look at provincial numbers. They're not known yet. However, the majority of physicians that are using non-OTN solutions are using a combination of audio and video. So I'm sure this is very similar to the experience that you've had, and I'm looking forward to hearing about your experience during the pandemic. But I'll just say that it's been a really busy time at OTN, and we're just pleased that we're able to kind of step up and be able to provide patients with access to care, because it's been a very uncertain time for a number of patients that still have a lot of healthcare needs and need access to their healthcare providers. So how did we respond? We implemented a COVID leadership team in early March, and we continue to meet on a regular basis. We kept our processes very agile. We had to make changes literally on the fly. We spent a lot of time with communications. We developed a COVID resource page on our website. We had a clinical team that was developing resources and member communications so that we could let our members know that we were experiencing an incredibly high volume on our network. We also had hundreds and thousands of physicians and providers that wanted to be onboarded literally overnight. So we had to call on our existing staff and train them on how to onboard and provision new members so that they could use our solution. And even though physicians were able to bill for non-OTN solutions, a number of them wanted to use OTN because of our integrated network, because we have access to a directory, and because we have scheduling, and because we have a trusted solution that's been around for a long time, and because we have multi-point functionality. They wanted to be able to use our network. So we wanted to do everything we could really to get them on board. But there was a bit of delay in getting some of our members onboarded until we got some of our volunteer staff trained to be able to get them onboarded. We probably did, in terms of our technology and our infrastructure, we probably did about 25 technology enhancements in 60 days. So with our video software, we were fortunate that it was already in the cloud, because that really enabled us. We use AWS, and that really enabled us to be able to build more capacity to be able to meet the demands. Our network wasn't really built, for 12,000 virtual visits a day. And we're in the process of building even more infrastructure because we expect that there's going to be a second wave. But fortunately, we've got a lot of experience in doing telemedicine and a lot of experienced technology folks. So we were able to meet that demand right now. So there's no delay right now in using our network, but we expect with the second wave that there may be more, so we have to get ready. We have operational processes that we continue to re-examine so that we're able to support our members and just to be really nimble. So we've trained, as I mentioned, we trained a number of staff. Those staff are on standby. We're kind of in a period of kind of a stabilization right now, but they'll be ready to go if the demand picks up again. In mid-March, we literally worked, we shifted to all of our staff working from home. We continue to work from home. We really have no idea when we're going to go back to the office. OH is saying that maybe September, although I think that's probably a bit optimistic. And really, we kind of are knowledge workers, so I think a number of us can continue to work from home. And because most of our technology is in the cloud right now, you know, we don't have to physically be in the office. Our offices are also located downtown. So there's a lot of people down there that have to use public transit. And so I think a lot of our staff will be happy to remain in their home offices. We also have regional offices across the province. And really, if you were outside any of the urban centers, you wouldn't even really know that there is a pandemic that's happening because they've had very few cases outside of the larger urban centers. And another thing that we're doing right now is we're really reflecting on our lessons learned. So, you know, apply what we've learned over the past four or 5 months to be able to get ready for that second wave, or what our clinicians are saying are going to kind of be ebbs and flows with this pandemic. But we expect that there's going to be a sustained demand for virtual care. So how do we get ready to do that? So these next 3 slides are really talking about some of our examples of virtual care innovation during the pandemic. The way that I'll talk about them is what we did for our healthcare community is we developed what's called kind of placemats. So this is a placemat for virtual care for mental health and addictions. And what we wanted to be able to do with these placemats is to say, look, there's already a number of virtual care solutions and programs that are happening in the province, because what happened is that providers were looking for access to virtual programs and solutions almost overnight. And there was no need for us to have to reinvent the wheel, but we needed to be able to connect the dots and be able to share that information with healthcare providers across the province so that they knew that these programs were available. And what the province did as well is they said, you know what, we're going to open up some of these programs. Initially were for pilots, and the province said, you know what, open them up. We're going to provide funding so that regardless of where providers or patients are in the province, we've got to get them access to care. So I don't have time to go through each of these, but I'd be happy to talk to them through the Q&A. I've talked about Big White Wall. We saw a huge uptake in consumers going directly to that solution. There was a lot of fear around the pandemic and anxiety and depression. And so we really wanted to be able to provide access to Big White Wall. Also, internet-based cognitive behavioral therapy. I mentioned that we were doing it with universities and colleges. The province made it available to healthcare providers, and they made it free for Ontarians. And because we did that innovation procurement a couple years ago, we had those solution providers that were ready to go. So that was great. So they got up to speed very, very quickly. So if, you know, regardless of where you live in the province, you have access to these mental health programs. We also have on our network a number of clinicians that provide mental health and addiction support for adults and pediatrics. We're also working with school boards across the province as a result of the pandemic, because school shut down in March. There was a lot of e-schooling, or what our parents called crisis schooling, that happened during the school year. And the school boards were very concerned about children that were getting therapy face-to-face that no longer had access to it. So we're in the process of signing up a telehealth for school-based therapists, psychologists, social workers, OT, and PT. We also have a virtual care clinic. It's called OVCC. We created this at the start of the pandemic, and it's 24/7 access to a physician. We encourage patients to call their own provider first. But some of those physicians were overwhelmed, and we didn't want patients to wait. We also had physicians that were not as busy and that were available virtually. So this is called seethedoctor.ca. You can log on. If you're a resident of Ontario, you put in your OHIP number, you go into a waiting room, and a physician will call you back. Within 15 minutes, 7,000 residents have accessed that service in Ontario, and we recently launched it in French. We've also provided access to additional resources. There are a number of other organizations that are doing amazing work and that are providing services virtually. We still have an opioid crisis in Ontario, and we understand from our providers that that's gotten worse. We have a number of substance use solutions that are available province-wide. One of those providers, Breaking Free, made their solution available, and that was up until July 31st, for 1 year of access. So it was just amazing to see providers that come to the table that just said, look, we have this service that's available and we want to help. So it's been pretty remarkable. The next placemat was around optimizing the resumption of surgery. So when the pandemic hit, hospitals really stopped all elective surgeries because we wanted to keep the hospitals open in the case that ICU patients would be the ICUs would be overwhelmed. So they stopped elective surgery. About 2 months ago, the ministry in Ontario Health said, okay, now you can start the resumption of elective surgery. And again, hospitals told us that they just don't have the capacity to bring these patients back into the hospital pre-op, and they want to get them out of the hospital sooner. And so we had a number of solutions through our vendor of record that we could say, hey, these are available for you to use pre-op and post-op. And we also had a number of hospitals that had actually implemented surgical transition solutions. So we put their links on this placemat to say, hey, if you're interested in learning more about how a hospital did it, here's the link. We provided a list of all the vendors of record that they could contact, and then also other solutions, remote care monitoring, which is already an existing program that they could leverage, and then support for primary care as well. So happy to take any questions on this slide. The last one was actually really interesting, and it was around providing local virtual access to emergency services. So in Ontario, prior to the pandemic, province-wide, there were about 500,000 emergency visits. Once the pandemic started, that reduced by half. So a lot of providers were very, very concerned that patients were not coming to the emergency department, and I'm sure you had a similar experience. And so they actually went virtual. So they developed kind of local virtual ERs. And one example was the Children's Hospital of Eastern Ontario. They actually became Canada's first pediatric hospital offering a virtual emergency department. So they leveraged their own solution. They didn't use OTN. And they promoted it through social media and other channels. Parents were able to log onto a CHEO website, fill out some information, and the physician would call them back. So the relief to parents and other patients that have access to these local virtual ERs was pretty remarkable. So pretty innovative in that these physicians were not going into the emergency department because the patients weren't there, but they were able to see these patients virtually. We also provided some international examples because we know that this is happening elsewhere. And so we've actually had, we had a session with a number of ER physicians that have actually said, look, we want to continue to do this because we know with the second wave, we can't have busy waiting rooms. We can't have sick children and parents coming back to an emergency that will be overwhelmed. So how can we start to integrate virtual care into our existing delivery model. So pretty remarkable what's coming out of the pandemic. So I'm just going to kind of wrap up a little bit. I'm just going to keep an eye on time. So in terms of what's next, so we know that, you know, with months of service reductions, you know, delayed elective procedures, routine screening, and clinics and physician offices closures is going to, you know, undoubtedly result in hopefully not too many untoward outcomes for many. However, we do really believe that there is a silver lining with this pandemic that's coming out of it, and that there's really going to be more virtual care. It's just inevitable. We're not going to go back. So what we're doing right now, as I mentioned, is that we're preparing for the next wave of COVID in collaboration with the ministry and our other Ontario Health partners. We expect, and this is a good thing, that several healthcare providers will continue to use their preferred solution for direct-to-patient video visits in the home. If their EMR has a video solution, if, you know, they want to continue to use the phone, depending on the needs of their patients, that's totally fine. However, sustaining a provincial network is really, really important. So that's something that OTN will continue to do. And we want to be able to ensure equity and access. So we're going to really continue to work on our provider journey to really make it interoperable with some of those third-party solutions, because what we've heard is that they want access to our directory and they want access to our scheduling. So there's no need to reinvent the wheel. So that's some of the work that we're going to, that we're starting to work on. We want to work with our external partners to promote the emerging models, to promote emerging models of care. What happened in the province, I've talked about long-term care. We really have to look at how we can provide better access to virtual care for long-term care providers, either through better access for primary care providers that go into long-term care homes using e-consults and other tools. And also what happened in the province is that when the pandemic started, home care providers actually prevented their patients from going into the home, their providers from going to the home, because there was so much unknown. And, you know, as it turns out, the home is one of the safest places to be. So there's a great need to really look at providing more home and community care. There's not going to be enough providers to be able to go into those homes. So we really have to look at scaling virtual care using virtual tools for home and community. We want to continue to modernize consumer access to care, because we know that more and more care will be delivered in the home. We're also working on a healthcare navigation service, so kind of a digital kind of front door for patients, so that regardless of what their needs are, that there's a front door for them to be able to access. And then we're going to continue to leverage our expertise in virtual care to support scale and spread. So we don't think that we're going to be any less busy, but we're just really happy that we can be here and continue to transform the healthcare system. My last slide is just kind of looking at some broader healthcare system lessons in Ontario. We need a tighter alignment between healthcare and public health. Those are two separate agencies that, you know, that kind of work together, but not closely enough. So we really need to look at building that bridge. You know, public health is health. And so we realized that there were kind of gaps in terms of what we saw during the pandemic. The long-term care crisis that we experienced in Ontario needs urgent attention to fix the staffing issues, personal support worker pay, and structural problems. The healthcare system really needs to focus on integrated home care delivery and address the failure of service delivery during the pandemic. Virtual care needs to be expanded and supported as a key tool to address health equity and improve the client experience, and that we need better transparency and better access to data. So I think I'm going to stop there. I hope we're doing okay for time and open it up to questions. Thanks very much.
You are perfect. Thank you so much, Lori. That was awesome. The innovation and the ability to pivot very quickly and with a very large population. So we do have some great questions from our audience. So I think we can kind of dig right into those, if that sounds good to you. The first question is about e-consults. And just to clarify, here in the US, we define e-consults as the peer-to-peer you know, usually primary care providers getting specialist consultations. So how are specialists recruited and reimbursed for e-consults in your network, and what outcomes or ROI have you seen through e-consults?
Oh yeah, I don't have the numbers handy, but I'm happy to get them. But as I mentioned, we started probably about 10 years ago with teledermatology, and the fee codes were actually the same as face-to-face. And so once we got more experience and our province looked at the numbers, they thought, you know what, it doesn't take as much time to do a virtual visit as it does, a face-to-face. So they actually modified. So we actually have two fee codes for eConsult, one for teledermatology and one for retinal screening. The other fee codes are kind of based on a fee schedule that's been established through OMA negotiations, or Ontario Medical Association negotiations. I don't have those handy, but I'm happy to get them. But as I mentioned, is that there's been remarkable outcomes for eConsult in the province. There was a very huge uptake for onboarding. Primary care has been asking for this for a long time because the wait list to see some specialists, and again, this is for consult, this is not referral, this is just for a consult, but even to do a consult, it would be upwards of 6 months for that patient to be referred. And now, as I mentioned, that those turnaround time is about 2 days. So it's pretty remarkable in terms of the outcomes. There's actually, and I'll forward this link to you, Danielle, that you can share with your folks, is that there's an organization out of Ottawa. They're called BASE, and they're actually the clinical providers that do all that coordination for eConsult. And her name is Dr. Claire Liddy. And she's just remarkable with some of the work that she's done around eConsult. She's published a lot on the outcomes in their programs. So I will share that link with Danielle today, and then Danielle, you can circulate it out.
Fantastic. Thank you very much. So a couple of consumer resource related questions. So I'll kind of link those together. So related to consumer resources, how do you support, So I wanted to read the first one. What kinds of consumer facing materials do you have to help patients understand and prepare for virtual visits? And I seem to remember you presented some of these at our conference, and we were blown away how wonderful they were. But if you wouldn't mind sharing.
Yeah, so we spent a lot of time doing that because it has to be very simple and very easy for patients to be able to do a virtual visit. And so that was our objective in doing our pilot, was to really understand what patients needed to be able to access a virtual visit in their home. And part of our experience was actually talking to patients because it's very easy to kind of focus on what the provider needs, but really you're not going to have a successful visit unless you really understand what it is that the patient needs as well. So we've actually developed a number of tools that are on our hub. So again, we have instructions for patients. We actually have developed emails. We actually developed the template for physicians and other healthcare providers that are providing direct-to-patient video visits to be able to send to the patients. Because it can be confusing for patients, and a lot of our patients are not tech savvy. And so when they got the email, it wasn't clear for them. So we went back and we reworked the email, and then we talked to patients. We actually did a patient focus group to say, what is it that you need? And what we experienced very early on is that patients were calling our technical support if they were confused about the appointment, or if they wanted to change the appointment. And our staff is not equipped to be able to handle clinical calls, right? We do not provide the clinical service. So we had to go back and make those modifications. So we had to be very specific to say, if you want to change your appointment, or if you have any questions about your appointment, to please contact your physicians. And here's their office, right? So we provide, that template, and then the clinic will just provide their information. But we also had to provide technical support for those patients to say, you need to make sure you have adequate bandwidth. So click onto this to see, whether or not you have adequate bandwidth. So, that's kind of going in the weeds a bit, but we actually have a user experience team that will work, with clinicians and our technical team to really make that what we kind of call the user experience very simple for patients. So that's all on our hub. But it's interesting, Danielle, if I can just elaborate on that a bit more. What we're experiencing, again, with the non-OTM solutions is that a lot of providers are going to audio. So this is something that we're going to continue to explore kind of throughout this pandemic, because I think there is a case for audio. If it's someone like myself that sees a specialist, once a year, a phone call is fine. But there's a lot of value kind of in this face-to-face as well. And we're hearing that from some of our patients that they would prefer, to have kind of that video visit. So there's still a lot of that change management as virtual care continues just to expand. How do we kind of promote what the best practices are as to whether or not it should be an audio call, or whether or not it should be virtual, or whether or not it can be secure messaging. The province is not reimbursing for secure messaging right now. But that is part of our roadmap. And then again, so what are the use cases for each of those?
That's awesome, because I know as telehealth resource centers, we've been getting lots of those questions, but there's not a lot of literature around that, right? Like the best practices for audio, because it hasn't been allowed in the past. So
Right.
That's really cool that you guys are studying that within your network, and we'll be really excited to see what kind of literature might come out of it. We'll be keeping our eyes and ears open for that, Lori. So related to the consumer resources, how do you support translation services?
Yeah, that's a really good question. It's never easy. I mean, we are required to provide our services in English and French. So we do that. Sometimes when we launch with a pilot program, our vendor is only has the solution available in English, but with the understanding that if this pilot is successful and it's scaled, it has to be available in French. So that's a requirement. We are now an agency, of the government, so that's even more important. Having said that, in Toronto, it's a very, very multicultural community. So a number of our service providers will provide translation services in over 140 languages. So they have a third-party organization that provides that translation support. So OTN does not provide that service. We're required to do it in French and English. For remote care management with our telehome care program, the nurse, if that patient does not speak English or French, say it's Farsi or Cantonese or Mandarin or whatever, we'll ask whether or not there's a family member that speaks English. If not, then the host organization that delivers the service will leverage their translation service to be able to support the patient in their home. With Aboriginal communities, it's a similar issue that we have to make sure that there are a number of dialects for First Nations languages. So that's something that we work with our First Nation partners in Northern Ontario. And it's a very important part of equity and access. So everything that we do, we have to make sure that we address, equity and access, and language support is one of those boxes.
Great. Yes, I know it's challenging to make sure that you have coverage for all of the various languages that your population might need. So great, thank you. So here's a great question that we're also getting a lot more of this happening here in the States, to be hopefully more proactively prepared moving forward. Has OTN worked with universities to integrate telehealth into their curriculum?
Yeah. Boys, I wish. I really wish. Right? I mean, I've been working. I mean, I have a nursing background, and I've been working in virtual care for over 20 years, and I'm a guest lecturer, at 2 universities, and every time I'm there, I'm talking, to the administrators around the need to really integrate virtual care into curriculum. Dr. Lynn Nagel is one of my mentors, and she is a professor at the University of Toronto, Western University, and the University of New Brunswick. And she actually just relocated to New Brunswick. And the University of New Brunswick has hired her to develop curriculum for kind of digital health or virtual care. So again, it's not at scale. But we really need those champions. We need all of you, right, to continue, to work, with your peers and your partners, because it's just imperative. In Northern Ontario, there's actually NOSM, is the Northern Ontario School of Medicine, and most of their care or their education is developed and delivered online. So I'm hoping that, now that we've got this pandemic, and knowing that universities are trying to figure out, right, how to bring students, or stagger students, or what the model is, that there's going to be more online learning. So I think it's just a matter of time. What universities have told me in the past is that they just don't have the budget. They just don't have the budget. But I think you're going to see a whole transformation around virtual online learning, and that's a good thing.
Perhaps maybe another silver lining to this
Yes, yeah,
challenge
for sure.
pandemic. And
Yeah.
if it's any consolation, we've had similar instances here in the States where maybe there was an elective course offered for different disciplines. However, we've seen many more requests for assistance with more core training for any different number of disciplines here in the States, because I think people, again, want to be more proactively prepared in case something like this happens in the future. And, just digital health is, I think, part of the future. So
That's right.
Great. Thank you for sharing that. So we have kind of a follow-up question to one of your earlier comments. Do providers always email the invitation link that you had mentioned? You had kind of those standard invites, or have you launched text messaging to send the links to?
No, not yet. Not yet. It's a great question. I think it's on our roadmap. And I think, again, as it just becomes more ubiquitous and we figure out those kind of workflows, but right now it's by email. And so, and the link for the virtual visit is in that email. So again, could easily be done by text. So again, and realizing that we actually just started with this pilot and we're ready to kind of scale it. And then we didn't really have time to scale. The pandemic actually has done our scaling for us.
Sure.
So we really didn't even had much time to kind of breathe, right? Like in terms of figuring out, but text it's just obvious, right? It's just obvious. And with our eVisit primary care, they're using secure messaging, which in essence, is texting, right? So surely can be done. Yeah.
Great. So I think we have just one more question so guys, if you have another burning question, please go ahead and put it in the Q&A. However, we will, as we have every week, provide the link in the Q&A section so that you can all join Lori for more of a face-to-face, one-on-one with your video and your audio turned on, so we can have that more sort of intimate conversation. And the link has now been posted in the Q&A. So last question, and we kind of got to this a little bit, but I thought you might want to elaborate on it just a little bit. How are you helping providers assess patient ability to use virtual care? How do providers know patients have the tech support to keep the video call up?
Yeah, those are always a challenge. And I think it's really understanding, again, one of the things that we've said, when we're launching direct to patient in their home is that we've had a lot of experience having patients coming into remote locations. And you've always got the support. As I mentioned, we've got over 2,000 telemedicine coordinators in the province that work really, really closely, in a clinic setting. So we've actually worked with some of them to be able to support those patients now that they're transitioning into the home. So I always think it's really important to have a pre-existing relationship, with the patient. Again, it all depends on the patient. Probably you or I would be fine, but we're not frequent users of the healthcare system, right? Frequent users of the healthcare system are people that, may have a chronic disease, maybe palliative, maybe older, maybe a child with special needs or whatever. So how do we make it very simple for them? So we work with some of those telemedicine coordinators that work directly with those patients to say, here's the checklist for you to be able to do that. And so they've worked with them. And once we kind of get through that first encounter, it's generally pretty good. So we want to make sure, of course, that, the patient has, a good working device in their home. It doesn't work for everybody because, as you saw in the map, there's still, a vast part of Northern Ontario that does not have adequate access to bandwidth. And that's why we need to continue to have those patient access networks that those patients have to continue to go in. So it's not all virtual. We know that virtual will continue to expand, but we need to continue to keep those sites. So it shouldn't be it should never replace a face-to-face. So I think that's a really important thing for providers. And that's something that we share with them, is that you really need to understand what your patient's needs are and whether or not they could even do, a face-to-face in their home. But we've had amazing stories where we had a woman who was 95 years old that, was too afraid, to go see her primary care provider. And so the admin person in the doctor's office worked with the patient, helped her text. She was used to using her iPad. And, the virtual visit was beautiful. And, she did her hair, she had lipstick on, and she said, it's just like being on TV. This is wonderful. It's just like being on TV. So, we shouldn't overcomplicate it, right? We just really not need to try to keep it simple, but really kind of understanding the patient experience. I just think is key. We do this, right, to provide better access to care. So
awesome.
that's ongoing.
That's great. So we actually did have somebody submit another question. It's a great question that I'll be really curious to hear your thoughts on. What is OTN's progress on mHealth applications, reviews, guidelines, guides, et cetera, to encourage confident recommendations for self-management by primary care providers? We know, like, mHealth creates all this data, right? And there's so many, everybody has a watch, a smartwatch, a smartphone, et cetera. So has OTN sort of developed some guidelines around that, or specific to recommendations for primary care providers and working with that data and their patients on self-management?
Yeah, no, it's it's huge, right? Like it's just huge in terms of so we haven't developed kind of mHealth kind of guidelines per se. We know that there's tons of solutions that are out there. And we have a lot of primary care innovators, that want to use their own solutions, and then that's totally fine. One thing that I didn't go into a lot of detail on, because it's pretty early days, is a healthcare navigation system. So we want to be able to provide, this will be funded by the government, but it'll literally be a digital front door for patients. So again, a lot of those mHealth applications could be behind kind of that front door. So again, if you want access, what is your need? If you have a chronic disease, you have diabetes, you can't get through to your primary care provider, or you can come through us first and do kind of a self-assessment. And depending on what that self-assessment shows, you can have access to a nurse. Or a diabetic educator or whatever, right? So a number of those tools. So we're trying to connect all the dots in Ontario. We have a service called Telehealth Ontario, which is a nurse triage and health information system. So that, again, that's 24/7. And, a child has a fever, the parent will call the line. That's not integrated with anything in Ontario, so it stands alone. And they're not virtual, right? It's all over the phone. So we want to get that behind that digital front door, so that it's all integrated. So regardless of what your need is, you come through that front door first, right? So a lot of those self-tracking apps, could be available, right? If you have diabetes, here are some great tools that are available and that are free and that have been vetted, right? Because one of the things that we did for the non-OTN solutions is that we came up with minimum standard requirements. So, because the province said to us, look, we understand that there are a bunch of solutions that are out there, but we want to make sure they're private. There's privacy and they're secure. They can do like multi-point calls and things like that. So we actually developed a solutions requirement document, and it's available on our website. So that you can look at that to say that if I'm going to do virtual care and I'm going to get reimbursed in Ontario, these are the requirements that I need to achieve. So if any of you are interested in that, I can share that with you. So maybe we'll do a similar thing for some of those kind of mHealth kind of applications, but not there yet.
Awesome. Well, great thoughts. And we are out of time, but I just want to thank you so very much again, Lori, for sharing all of this information. And we will, we promise, guys, follow up with some of the resources that Lori specifically mentioned. I think we can embed those right in the app for you. So that'll be fantastic. Just as a quick reminder, we would love for you to please go into the app and fill out the evaluation form, because we really rely on you all, your feedback, so that we can continue to improve upon how we're offering these virtual series. So thank you so very much. Lori and our team are going to hang out here, as always, for an extra few minutes. So you can actually, the link to the Zoom where you can find us is at the very top of the Q&A. So you just need to click on that link, and we'll be waiting here to dive into a few more of your maybe in the weeds questions. And we thank you so very much, Lori, again, for sharing everything. And we will see you all again real soon.